Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
You can execute a structurally flawless 6-hour bowel resection, right?
Wow.
Like perfect hemostasis.
Oh, absolutely. Textbook surgery.
Right. You perfectly close the abdomen, and yet there's this transient, seemingly harmless blip in the patient's serum creatinine, like 24 hours later.
Yeah, just a tiny bump.
Exactly. And that little blip can be the exact trigger that dictates their mortality, 5 years down the line.
It's sobering to think about.
It really is. I mean, we usually frame surgical success around mechanical precision on the table, but the true battleground often shifts to the invisible metabolic cascades happening long after the drapes come off.
Right, in the ICU or the recovery room.
Yeah. So today, we're analyzing that specific battleground. We are talking directly to you, the surgeons, anesthesiologists, intensivists, and APPs managing these complex cases every single shift. We are zeroing in on a highly focused, critical perioperative challenge.
Acute kidney injury.
Yes, AKI in surgical patients. And I mean, the clinical perception of perioperative AKI just has to evolve.
Yeah, it really does. And we are pulling from a dense stack of literature for this deep dive today. We're synthesizing the latest KDIGO guidelines, perioperative consensus statements, and some really heavy primary research out of the BMJ, Nature, and NCBI databases.
A lot of ground to cover.
Yeah, a ton. But the mission here is to cut through the noise, cut through the institutional dogma, and just extract the actionable, evidence-based nuggets.
Right, on preventing, recognizing, and managing perioperative AKI.
Exactly. We want to help you protect your patient's renal function from the pre-op clinic all the way to outpatient follow-up. But before we unpack all this data, I do need to give a quick disclaimer.
Of course.
Please note this content is for reference only. Always follow your local hospital guidelines and protocols in your actual clinical practice.
Perfect. So let's jump right in. The first major paradigm shift in these sources is, well, it's the modern redefinition of the threat itself.
Right. We are no longer waiting for catastrophic anuric renal failure to sound the alarm. Those days are gone.
I mean, thank goodness. But the KDIGO criteria, it stages perioperative AKI based on acute rises in serum creatinine or, reductions in urine output.
Right. Stages 1 to 3.
Yeah. But the literature emphatically stresses that even stage 1, that's a rise in creatinine of just 0.3 milligrams per deciliter. That is an independent predictor of long-term mortality.
And chronic kidney disease progression.
Yeah.
Yeah, the magnitude of the risk associated with the 0.3 bump, it really cannot be overstated.
It sounds so small.
It does. We tend to view these small creatinine elevations as like transient functional dips.
Yeah.
Assuming the kidneys will just bounce back once the systemic hemodynamics stabilize.
Right, like they're just taking a quick nap.
Exactly. But the data tells a much darker story. That small rise actually represents structural cellular damage.
Wow.
Yeah. You have to remember, the renal medulla is essentially operating at the absolute edge of hypoxia baseline. The medullary nephrons, they extract oxygen at a near maximal rate just to run their ion pumps.
I was actually looking at the renal blood flow distribution in that Nature paper, and it frames this perfectly. Think of the kidneys as the body's meticulous curtains, right?
I like that analogy.
Yeah, you might think a tiny temporary error in the ledger, a small creatinine bump is no big deal if it resolves. But the data shows it's actually a red flag predicting long-term bankruptcy for the patient's health.
Because of that hypoxia edge.
Right. The kidneys might receive 20% of total cardiac output, but the medulla gets just a tiny fraction of that.
It's like a high-performance engine constantly redlining.
Exactly. So if you drop the systemic mean arterial pressure even slightly, you are starving a redlining engine of oil. The ischemia isn't a temporary functional pause. It is causing immediate tubular necrosis.
And that necrotic damage, it leaves a permanent scar. A scar which fundamentally alters the patient's long-term cardiovascular and renal trajectory.
So we really can't just be reactive here.
No, absolutely not. If we wait for the creatinine to rise, the engine is already seized. Defense has to start in the preoperative phase.
So we're talking about identifying patients whose medullary engines are already compromised before we even cut.
Precisely. We need to be profiling patients with pre-existing CKD, diabetes, heart failure, and definitely those slated for major abdominal or cardiac procedures where, large fluid shifts are basically guaranteed.
Right. Setting up that pre-op defense means eliminating friendly fire before the patient even reaches the holding area.
Discontinuing the nephrotoxins.
Yeah, the sources outline a strict discontinuation. We're talking NSAIDs, aminoglycosides, high-dose vancomycin, and iodinated contrast.
All the usual suspects.
But wait, I have to bring up something that really stood out. The guidelines regarding ACE inhibitors and ARBs, it presents this fascinating physiological tension.
Oh, the RAAS blockade issue.
Yeah, because in the chronic setting, we usually think of ACE inhibitors as fiercely kidney protective, right? Like specifically to preserve the glomerulus.
They absolutely are long-term.
But the consensus guidelines here say to withhold them for 24 to 48 hours prior to major surgery. I mean, why strip away that protection right when they need it most?
It's a great question, but we have to decouple chronic protection from acute intraoperative hemodynamics.
Okay, walk me through that.
Well, the immediate threat during the induction and maintenance of general anesthesia is profound vasodilation and hypotension, right? Normally, the body compensates for a drop in systemic pressure by upregulating angiotensin II, and that powerfully constricts the efferent arteriole in the glomerulus to, maintain filtration pressure.
Oh, I see. So if the patient has an ACE inhibitor or an ARB on board?
That compensatory efferent constriction is completely paralyzed.
Wow. So when the propofol drops their systemic MAP, their glomerular filtration pressure just totally falls off a cliff.
Exactly. The synergistic effect of anesthesia and RAS blockade transforms a routine induction into a massive ischemic hit.
Which leads directly into the intraoperative strategy, I guess.
Yes. Once the patient is on the table, mitigating that ischemic hit requires goal-directed hemodynamic therapy.
Rather than what we used to do, right?
Yeah.
The literature strongly favors this over the traditional restrictive zero-balance fluid regimens.
Yeah, those became popular for protecting the pulmonary vasculature, keep the lungs dry.
Right. Running a patient bone dry might keep the lungs pristine for extubation, but you are literally sacrificing the kidneys to do it.
It's a dangerous trade-off.
So the goal-directed approach, it relies on dynamic, continuous assessment of fluid responsiveness. You're watching stroke volume variation, pulse pressure variation, or even using intraoperative TE.
Transesophageal echo, yeah. You need to determine if a fluid bolus will actually augment cardiac output.
And increase oxygen delivery to those vulnerable medullary nephrons we were talking about.
Right. It forces the anesthesia team to constantly balance the macro and microcirculation.
Right.
Because pushing indiscriminate volumes of crystalloid is just as destructive as running them dry.
Too much fluid is just as bad as too little.
Absolutely. Hypervolemia degrades the endothelial glycocalyx, it promotes tissue edema, and crucially, it increases renal venous congestion.
Which paradoxically reduces renal blood flow.
Exactly. Goal-directed therapy ensures you're only giving fluid when the heart is operating on the steep portion of the Frank-Starling curve.
Makes total sense. Okay, so surgery ends, the drapes come off. Now we transition into a highly volatile 24 to 48-hour post-op window.
The danger zone.
Yeah, because despite optimal goal-directed intraoperative management, the surgical trauma itself induces a massive inflammatory and metabolic cascade.
And the KDIGO guidelines really emphasize how we monitor during this phase.
Right. They say tracking absolute thresholds for creatinine is way less useful than tracking the velocity of the change.
Yes, the trend is everything.
It's like stock market analysis, right? You can't wait for the total market crash to act. If you see the trend line dipping in those first 24 hours, like if urine output trends down or creatinine creeps up by just 0.1, you have to initiate the diagnostic workup immediately.
Because time is nephrons. When those trends emerge, you have to mentally divide the etiology into pre-renal, intrinsic, and post-renal categories.
Post-renal is usually the easiest to rule out, right?
Yeah, obstruction is usually rapidly ruled out with a bedside ultrasound or a quick bladder scan. The real diagnostic heavy lifting is differentiating pre-renal hypoperfusion from intrinsic tubular injury.
Because unresolved prerenal ischemia rapidly progresses to acute tubular necrosis.
Exactly. You want to stop it before it crosses that line.
So the initial assessment means pulling every available hemodynamic data point. Detailed fluid balance, continuous MAP trends, heart rate, lactate clearance, and basic urine microscopy.
But there's a massive trap here that the BMJ source highlights.
Oh, the surgical etiology that overrides the standard algorithms.
Right. Intra-abdominal hypertension progressing to abdominal compartment syndrome. We see this in trauma, ruptured AAAs, and massive bowel resections with third spacing.
I mean, the pathophysiology there is purely mechanical, isn't it?
Entirely mechanical. If the intra-abdominal pressure exceeds 20 millimeters of mercury, it physically compresses the renal veins.
And the kidneys are encapsulated organs, so they can't expand.
Exactly. When the venous outflow is strangled, The backward pressure gradient rises exponentially. The renal interstitial pressure eventually matches the mean arterial pressure.
Which just completely halts arterial inflow.
Yep. No blood in, no urine out.
Wow. And no amount of crystalloid or vasopressor is going to force blood through a mechanically compressed organ.
No, the only cure for that specific phenotype of AKI is immediate surgical decompression. Opening the abdomen instantly drops the venous resistance.
And restores the pressure gradient. But okay, let's assume we aren't dealing with compartment syndrome, right? We have a hyperperfused pre-renal picture.
The standard clinical reflex is to reach for a fluid bag.
Right, but the guidelines are highly specific about what should actually be in that bag.
Very specific. The consensus is definitive. Isotonic balanced crystalloids are the resuscitation fluid of choice.
So no colloids.
No. The use of synthetic colloids, specifically hydroxyethyl starches, is contraindicated in patients at risk for AKI.
Yeah, the mechanistic data on that is wild. The proximal tubule cells actually take up those starches via pinocytosis?
Yes, they literally swallow the starch molecules.
And it leads to massive cellular swelling, luminal occlusion, and severe osmotic nephrosis. I mean, it's a completely iatrogenic, intrinsic injury.
We do it to them. So yeah, we stick to balanced crystalloids guided by those dynamic parameters. But once you've optimized the volume status, once the tank is full, you have to artificially tighten the pipes to maintain perfusion.
Right, which means initiating vasopressors, typically noradrenaline, to maintain an MAP of at least 65.
Though in patients with chronic hypertension or in septic and major abdominal cases, you often need to target a higher MAP.
Like 75 to 85.
Yeah, frequently necessary to overcome the elevated renal vascular resistance and just force blood into those glomerular beds.
And while you're manipulating all these hemodynamics, you also have to constantly recalculate the estimated GFR and, adjust your medication dosing.
The ICU is a minefield of secondary nephrotoxins.
Totally. Antibiotics, opioids, sedatives, low molecular weight heparins if the renal clearance drops. The half-life of these drugs skyrockets.
Leading to compounded toxicity.
Yeah.
But, there is a massive trap in the management of this phase, one that goes against deeply ingrained clinical instincts.
Oh, we have to talk about this. The diuretic myth.
Yes. We have been conditioned to view urine output as the ultimate proxy for renal health.
Right. I mean, when a patient is oliguric, the overwhelming temptation is to just administer a loop diuretic like furosemide. You just want to force diuresis and make the numbers on the flow sheet look better.
But the KDIGO guidelines explicitly state that diuretics should not be used to prevent or treat AKI.
Wait, really? Why is forcing diuresis actually a bad thing if the kidneys are failing? It feels so wrong to just let them not make urine.
Well, think about what furosemide actually does. It blocks the sodium-potassium chloride symporter in the thick ascending limb.
Okay.
It forces the excretion of urine, sure, but it does absolutely nothing to improve renal blood flow or resolve the underlying drop in GFR.
So you're just treating the monitor while ignoring the physiology.
Exactly.
Yeah.
And it's actually worse than just treating the monitor. If the patient's oliguria is driven by a pre-renal hypovolemic state, forcing diuresis actively depletes their intravascular volume even further.
Oh, wow. So you are actively accelerating the ischemia.
Yes. Furthermore, diuretics increase the metabolic workload of the distal tubular cells. You're increasing their oxygen demand right when their supply is compromised.
Okay, so when do we actually use them?
Diuretics are strictly reserved for managing volume overload and pulmonary edema.
Yeah.
They have no place in reversing the AKI itself.
That is such a critical distinction. All right, so what if dynamic fluid management, pressors, and, avoiding iatrogenic harm aren't enough to reverse the trend? The patient tips into the metabolic danger zone?
That's when things get really critical. The kidney's failure to maintain homeostasis leads to life-threatening derangements.
Like hyperkalemia and metabolic acidosis.
Right. Managing hyperkalemia in this setting relies on rapid temporizing measures. You give IV calcium to stabilize the myocardial cell membrane.
Followed by insulin glucose and beta agonists to drive potassium intracellularly.
Exactly. And for the metabolic acidosis, the instinct is often to push sodium bicarbonate.
But the guidelines mandate extreme caution there, right?
Very extreme caution. Bicarbonate administration is generally reserved for severe acidemia, defined as a pH less than 7.2, and only in patients who can actually tolerate the massive sodium and fluid load that comes with it.
Because if they are already volume overloaded, pushing bicarb just precipitates flash pulmonary edema.
Right. You fix a number but drown the patient.
Oof. Now, this metabolic deterioration also forces a reevaluation of nutrition, which I found super interesting in the NCBI sources.
The protein restriction debate.
Yeah. Historically, the surgical dogma was to aggressively restrict protein intake in AKI patients, right? To minimize uremia and delay the need for dialysis.
But the current perioperative guidelines completely abandon that approach.
Thank goodness.
Yeah.
Because the metabolic reality is that these post-operative patients are in a massive catabolic state.
They are burning through muscle mass to heal the surgical trauma.
Right. If you restrict enteral protein, you just exacerbate their malnourishment and drastically increase their risk of sepsis and wound dehiscence.
We must maintain standard enteral nutrition protocols and rely on strict protocolized glucose control targeting 110 to 180 milligrams per deciliter to optimize their cellular metabolism.
Okay, but what happens when the hyperkalemia becomes refractory or the acidosis becomes unmanageable?
Then we hit the threshold for renal replacement therapy, RRT.
And the timing of RRT initiation is like one of the most debated topics in critical care.
It has been, but the recent literature provides remarkable clarity now. The absolute indications are clear. Refractory hyperkalemia, severe intractable acidosis, refractory volume overload causing pulmonary edema, and overt uremic complications.
Like encephalopathy or pericarditis.
Exactly.
But what's critical is what is not on that list. You don't initiate dialysis prophylactically just because the creatinine hit a specific number or, the patient has been oliguric for 12 hours.
No, absolutely not. The data demonstrates unequivocally that early RRT confers no mortality benefit, and it significantly increases the risk of long-term dialysis dependence.
Why is that? I mean, shouldn't early dialysis give the kidneys a break?
That's the old thinking, but we have to respect the physiological toll of the extracorporeal circuit. When you place a patient on RRT, you are pulling hundreds of milliliters of blood per minute into a machine.
Right, which causes profound transient hemodynamic swings.
Exactly. So for a kidney that is already ischemic and struggling to recover, these dialysis-induced hypotensive episodes constitute secondary ischemic hits.
Ah, I see. So by jumping the gun and starting RRT too early, you aren't giving the kidneys a rest at all. You are potentially prolonging their failure.
You're just hitting them while they're down.
Okay, but when the absolute indications do force your hand, the choice of modality matters too, right?
Yes. Continuous renal replacement therapy, or CROT, with effluent doses targeted around 20 to 25 milliliters per kilo per hour is vastly preferred.
Especially in hemodynamically unstable patients or those with acute brain injury.
Because it allows for much slower, gentler fluid and osmolar shifts compared to intermittent hemodialysis.
And the moment the intrinsic renal function shows signs of recovery, like improving endogenous urine output, stabilizing electrolytes, the RRT must be aggressively discontinued.
It's a temporary bridge, not a permanent destination.
Exactly. So let's follow this clinical arc to its conclusion. The patient survives the ICU, the creatinine trends back toward baseline, and they are discharged from the surgical ward.
Historically, the surgical team considers the AKI resolved and the complication managed. High fives all around.
Right. But the Nature and BMJ sources insist on a complete paradigm shift here. The acute episode in the hospital is merely the initiation phase.
This brings us all the way back to the structural scarring we discussed at the very beginning.
Yep. Patients who sustain perioperative AKI, even transiently, carry a vastly increased risk of developing incident CKD and accelerated cardiovascular disease.
So the guidelines mandate that these patients have their renal function formally reassessed 1 to 3 months post-discharge.
That follow-up requires checking a new serum creatinine, calculating a new baseline eGFR, and aggressively screening for albuminuria.
Because the acute insult unmasked a chronic vulnerability. Long-term management has to pivot to strict blood pressure control, optimizing diabetic regimens, and deploying nephroprotective agents in the outpatient setting.
Just to slow the inevitable progression of the disease, which honestly introduces a really provocative concept looking toward the future of critical care.
On the predictive analytics.
Yeah, because we currently rely on lagging indicators, right? Creatinine takes hours or days to reflect an injury that has already occurred. But given everything we've unpacked, how even a tiny transient bump in creatinine changes a patient's long-term mortality, should we stop viewing perioperative AKI as just a temporary surgical complication?
And start treating it as the first day of a chronic cardiovascular disease that was unmasked in your OR.
Exactly. And imagine a near future where machine learning algorithms continuously ingest high-fidelity MAP waveforms, stroke volume variations, and real-time urine output data to predict an AKI event 6 hours before the cellular damage even begins.
That would change everything. Instead of reacting to a rising creatinine with a vasopressor, the algorithm prompts the anesthesiologist to adjust the hemodynamics before the medullary nephrons ever experience hypoxia.
Right. We would no longer be treating AKI. We would be preempting the structural damage entirely.
The integration of predictive continuous monitoring is going to completely revolutionize perioperative medicine. We are moving from reactive damage control to proactive physiological preservation.
It's a fascinating frontier for clinical practice, something really profound to mull over on your next shift. And to all the medical professionals navigating these complexities on the floor and in the OR right now, if you found this deep dive valuable for your practice, please don't forget to share it with at least one of your colleagues or friends to help spread the word.
Definitely. The more people tracking these trends, the better.
Absolutely. Check out our YouTube and other social media pages, and definitely dig into our previous season and deep dives where we cover more highly relevant clinical topics just like this one.
Protect those nephrons.
Stay vigilant with your hemodynamics, and we'll catch you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.